Hi friends, so in this video we are going to discuss about atrial fibrillation. It is a very common arrhythmia overall, and in ICU practice also it is the most common arrhythmia that is seen in the ICUs. So I thought it is very important for us to discuss that. It is a very challenging topic and the students find it very difficult. So I thought I will cover that and I will make it simple for you. So as I told you, it is one of the most common arrhythmias seen in the ICU. It is a supraventricular arrhythmia, as the name suggests. Atrium is above the ventricle and above the AV node. So it is a supraventricular arrhythmias in that sense. Why are ICU patients more prone to develop atrial fibrillation? So there are several risk factors. These include advanced age, above 70 years. Critically ill patient itself is a risk factor with a Pache score of more than 25. Patients with background of cardiac disease, background of severe pulmonary disease, patients with electrolyte and metabolic derangements, patients with thyroid abnormalities, mainly hyperthyroidism. These are the common risk factors that I can think of which lead to precipitation of AF. Now, what are the causes for atrial fibrillation to happen? And this, in general, can be applied to any of the arrhythmias that we see in the ICUs. And these are your 5H and 5Ts, which you learn in the ACLS management. So these include your hypoxia, hypoglycemia, hypothermia, hydrogen ion, hyperkalemia. 5Ts include coronary and pulmonary thrombosis, tension pneumothorax, cardiac tamponade, toxins. One more thing I would like to put for atrial fibrillation particularly is mechanical factor. So sometimes when your lines go beyond your superior vena cava and the tip of the lines irritate your atrium in the right heart, patient can develop atrial fibrillation because of the irritation. Another important risk factor is sepsis, so that is also there. So when the patient is septic and with all these backgrounds, these patients are more likely to develop any arrhythmia, but more so with atrial fibrillation. Now let us discuss first the normal conduction system of heart. So as you can see in this diagram, the normal impulse starts from the SA node, which is situated in the right atrium, and then it travels through all of the atria, and it travels into the AV node, and then travels further down to bundle of his right and left bundle, Purkinje fibers, and eventually into the left ventricular, both the ventricular muscle. So this is how the electrical impulse passes, and to simplify, whatever abnormality happens above the AV node, that is called supraventricular arrhythmia. Whatever abnormality happens below the AV node, that is called ventricular arrhythmias. And how do you know it? So the normal impulse leads to a normal ECG, which translates into a normal contraction of one cardiac cycle. And as you can see, the normal ECG, P, QRS, and T, these are the waves. So P waves represent the atrial contraction, QRS represents the ventricular contraction, and T wave represent the repolarization or relaxation of the ventricles. So whenever there is any problem below the AV node, which involves the ventricular contraction, your QRS will be broad. So that will give you some idea that there is some problem with the ventricular transmission. Whenever there is a problem with at the level above the AV node, then that is the supraventricular arrhythmias, and in all the supraventricular arrhythmias, the QRS will be narrow, except for any pre-existing delay because of any other problem below the AV node. But otherwise, in a newly diagnosed arrhythmia, all the supraventricular arrhythmias will have a narrow QRS. So whenever you see the duration of QRS by broad and narrow, the cutoff is 120 millisecond. So that's about the supraventricular ventricular arrhythmias. Also, when there are supraventricular arrhythmias, there is problem with at the level of atria or SA node. So you will see altered morphology of your P waves. So your P wave will not be typically the way it looks in your normal ECG. So that we will discuss in the further course of this discussion, what are the changes seen in the P waves. Okay, So that's about the normal conduction. So that's about the normal conduction system of the heart. Now, what happens in atrial fibrillation? So there are two mechanisms by which atrial fibrillation can be triggered. One of them is ectopic pacemaker. So as the name suggests, any area apart from SA node in the both the atria can take over as a pacemaker. It starts beating at a rate faster than your sinus node, and that leads to atrial fibrillation. So that's called ectopic pacemaker. And second one is re-entry. So for re-entry to happen, there are three prerequisites which should be there. So these include the first one being at least two pathways for the impulse to transmit, the second one being unidirectional block in one of the pathways, and the third one being slow conduction of impulse in the other pathway. So I don't want you to go into details of this because I don't think it will help you in any way for the ICU management, but just for the sake of completion of the topic, I am discussing it here. So these are the two mechanisms, common mechanisms through which atrial fibrillation can originate. Now, what are the factors which lead to sustained or maintained atrial fibrillation? So, whenever they originate for by these two mechanisms, there has to be some pathology in the heart which will lead to continuation of the abnormal rhythm. So, it can be atrial remodeling or electrical remodeling. So basically what happens is because of dilatation secondary to structural problems or valvular problems or LV problems, pressure related problems, various reasons, the myocardium becomes stretched and eventually fibrosed, and that can lead to continuation of the atrial fibrillation rhythm. So some structural abnormality leading to atrial remodeling is one of the reason. Second one being electrical remodeling. So because of the same reasons, sometimes the refractory period is changed, sometimes the conduction velocity of impulse is changed in that area, and that leads to continuation or persistence of the atrial fibrillation which originated because of the previous reasons that we discussed. So now we will discuss about symptoms of the atrial fibrillation, and that depends whether the patient is conscious or not conscious, and in ICU both the things can be possible. So if the patient is conscious, they will complain sometimes about palpitation. If the atrial fibrillation leads to decrease in cardiac output, the patient will complain about lightheadedness, breathing difficulties, easy fatigability. These are the common symptoms, and also the symptoms secondary to the underlying problem that we have discussed in the previous section. So that's about symptoms. If the patient is unconscious or comatose or sedated, then you may not see any symptom except that you may see hypotension and signs of shock if the patient's heart rate increases suddenly, and you can associate that with the atrial fibrillation, that this change in the rhythm and rate is leading to shock. So that's about the symptoms. So when you see atrial fibrillation in your unit, how will you respond? So I think our goal, so the investigation and management should go hand in hand. What investigation do we do? So we do a 12 lead ECG to first ensure that the diagnosis is correct. What will you see in the ECG? So you will see narrow complex QRS, irregular pattern of the QRS, increase in the rate, obviously above 100, sometimes above 150 up to 200. No normal morphology of the P waves. So you may see sawtooth-like pattern in atrial flutter, which is also similar, and sometimes you see just fine fibrillatory waves. So because the typical morphology is not there, because SA node is not the pacemaker here. So these are the common changes. If the patient is in the ICU or in the hospital, you may have access to the baseline ECG, and in this baseline ECG you may see predisposing factors like left ventricular hypertrophy, signs of ischemia, Q waves or STT changes which might be there before. You may see some ectopics which may give you hint that this patient was prone to develop atrial fibrillation. Apart from ECG, you need to do arterial blood gas to find out about acidosis. You need to do the electrolytes, calcium, magnesium, potassium. These are the three common electrolytes which can lead to abnormalities, can lead to atrial fibrillation. You may have to do thyroid function test, which include free T4 and TSH for ICU population. You have also to do a 2D echo test to find out various things. So what do you see on 2D echo? You see the size of the atria, whether they are dilated or not. You see the size of the ventricles. You see the function of the ventricles. You see the valvular abnormalities, if there are any abnormalities like mitral stenosis or mitral regurgitation, which might lead to dilatation of the atria. You might see the pericardium, whether there is any pericardial disease, whether there is pericardial fluid collection. These are the common things. Sometimes you can even see a presence of thrombus in the left atrium, which is because of the long-standing atrial fibrillation. So when the blood is slowed down in the atrium, and the stasis that leads to a clot formation, and this clot can eventually embolize in the body anywhere, but the most dreaded site being brain, and the patient can have a stroke. So that's the concern for us when the patient has atrial fibrillation. So that's about the echo. So now we have done a workup, we have ordered a workup, we are doing workup. At the same time, it is always wise to give a small fluid bolus to see whether patient is hypovolemic. You have to bear in mind that this patient can be in fluid overload. The left ventricle can be very poorly functioning. There may be a valvular heart disease or signs of pulmonary edema. So your initial fluid bolus would be like a very cautious fluid challenge of maybe around 200 or 250 mils, and you see the response, whether the patient's heart rate is improving, whether the blood pressure is improving, and if not, then probably we don't go on that line. But you always need to see whether the patient is fluid responsive or not. So that's the first thing. The other thing is what you want to do is to control the rate. So there are two options, as you know, whether to control rate or whether to control rhythm. It is a debate which we will discuss later in the later part of this lecture, but I think at this point let's say that we'll control the rhythm, because it is a new onset atrial fibrillation. And what are the options that we have for rhythm control? It may be a pharmacological, or it may be electrical cardioversion. Pharmacological options are amiodarone and sotalol, amiodarone being most commonly used antiarrhythmic for atrial fibrillation. And electrical means obviously you need to give a synchronized cardioversion, you need to give a DC shock. When will you do electrical cardioversion, or for that sake any kind of cardioversion? When the patient is unstable, or when the symptoms are too much persistent for the patient, and you need to then control the rhythm. Otherwise, rate control is also a reasonable strategy to begin with. Along with your rate and rhythm control, you need to also manage the underlying problem that has probably led to the origin of AF. So this includes your left ventricular failure, your excessive hypertension, pulmonary embolism, exacerbation of COPD, thyroid storm. These are the underlying conditions which needs to be looked at when you are treating AF. So that's about the rate and rhythm control. You need to also think about anticoagulation. So if your onset of atrial fibrillation is less than 48 hours, you can cardiovert this patient. But if the onset is longer than that, or if it's a chronic AF, or if you don't know the onset, then probably ideally you should do a transesophageal echo to rule out any LV thrombus, and then you should go ahead and cardiovert the patient. If there is a thrombus, or if you can't do a transthoracic echo, then probably you have to weigh the risk and benefit, but ideally you should anticoagulate this patient for at least 3 weeks. Now say your patient is getting discharged from the unit, or for long-term management, if the AF is persistent, you have to give a strategy to prevent systemic embolization, and for that you need to anticoagulate the patient on long-term basis. So the options that you have is vitamin K antagonist, direct thrombin inhibitors, factor 10A antagonist, and your heparins. So we will discuss one by one. So vitamin K antagonists are the drug of choice in general for AF, for long-term anticoagulation. If there is a valvular heart disease, then also, which has led to AF, then also vitamin K antagonists are the drug of choice. your factor 10A inhibitors and direct thrombin inhibitors are soon replacing vitamin K antagonist because they have less side effects, they have less interactions, they don't require frequent monitoring of INR. At the same time, they are not recommended for valvular heart disease, which leads to AF. So that you need to keep in mind. For ICU population, probably starting with heparin or low molecular weight heparin makes more sense. And once the patient is stable and goes to ward or maybe to the to home and being cared at the outpatient level, then at that point you may switch to any of the oral anticoagulation. In which patients do you want to start anticoagulation? So for that you need to know Chad's VAS score. So as the name suggests, it's chronic heart failure, hypertension, age more than 75, diabetes, stroke, uh, vascular disease, age 65 to 75, and so there are 1 point for each except for stroke and age more than 75, which have 2 points. And if the total is 2 points or above, these patients will benefit from anticoagulation and will have a substantially less chance of having a systemic stroke. So these patients where the score is 2 or more, you need to anticoagulate. There is at the same time you need to evaluate risk of bleeding. So has bled score is one score. There are other scores as well. So you need to evaluate whether this patient has a higher risk of bleeding, and if it is so, then you may need to cautiously take a decision. It's always better to involve a cardiologist in such things, and also involve the patient and discuss the pros and cons before you start anticoagulation for such patients. So that's about anticoagulation. So now in the last we will discuss whether rate control or rhythm control is important, and if you look at the data, the studies that have been done so far, the mortality and severe morbidity with rate control and rhythm control is practically same. So there is no difference. However, rhythm control is preferred when the patient presents first time with atrial fibrillation, when the patient is young age, when the symptoms are too much to tolerate because of the abnormal rhythm, and when there is some structural damage or remodeling which has taken place, then probably your rate control will not help this patient, and the patient may be predisposed to a long-term chronic atrial fibrillation. So then also you go for rhythm control. What are your options for rate control? So basically what you do is you block the AV node. So your beta blockers, your calcium channel blockers, and digoxin. These three options are there for rate control. For rhythm control, you have drugs, you have synchronized cardioversion, and you have other electrophysiological treatments. So the drugs that you have are amiodarone, sotalol, amiodarone being the most commonly used drug in our unit. You can very well cardiovert the patient. We discussed the indications in the previous discussion. And you can do a catheter guided radio frequency ablation around the area of pulmonary veins where there is a highest incidence of re-entry. You can, if it is still refractory, maybe you can surgically try and ablate the areas which are the culprit areas and try and stop this abnormal circulation. So these are your options for rhythm control. Sorry. So I think that's all about atrial fibrillation. I hope this video may be useful for you and may increase your confidence in managing patients with atrial fibrillation in your ICU. And I hope you liked this video. Please hit like button, subscribe to my channel, and till the next video, goodbye.